We get started. Super.
You can go.
All right. Well, thank you very much for the opportunity to talk about equal access to bone marrow transplant. So my name is Anne-Pierre, and I received a bone marrow transplant in 2014. And so I'm a proud 8 3/4-year-old, as children would say. So that's my rebirth. And why do I advocate for access to bone marrow transplant? Well, for you to understand my involvement in this, I'd like to share a story, 2 patient stories, mine and that of Tiana. So Tiana received a bone marrow transplant in 2018, and we both had an equal need for bone marrow transplant, regardless of the year. So you may already be familiar, but it took actually, as a patient advocate, took me a while to actually get the sort of the patient journey from the bone marrow transplant perspective, right in my head. So I wanted to share that with you. We can run through this. So if there's an indication for bone marrow transplant is actually set by a hematologist, then they start to look for a match. So a 10 out of 10 match-related donor. So that's a brother or sister. That's the initial sort of step that you do. So you look for an identical 10 out of 10 HLA. But then you might think like, what is an HLA? What is this? So really the HLA system is like some sort of genetic ID card that we inherit from our parents. So that's what sort of it looks like. So you see the father, the mother, and you see some numbers and figures, and I'll go to that. But literally, this HLA system is made of 2. So you've got 2 sets. You inherit 1 set from the father, 1 from the mother, and these sets are known as haplo. That's the term for it. And you can see on the slide, you've got, for example, A3, B6, C15, DR3, DQ2. So these are parameters or alleles, that's sort of because it's genetic code, that this is where the match, you need to fully match on each on these different items. So the A, the B, HLA A, HLA B, HLA C, the DR, the DQ. So that's for the set, the haplo from the father, and then the haplo from the mother. So that's 10. You've got 10 sort of criteria that you need to match on. That's why it's called 10 out of 10 HLA. So brothers and sisters are a 10 out of 10 match when they actually share the same 2 haplo sets. So here on this slide, this would be, so the patient here on the left-hand side, and then the sibling number 4 they both share the same HLA system because they both share those 2 identical haplos. So this is just the terminology, and you probably heard hematologists talking about a 10 out of 10. This is what they're referring to. They match on those 10 criteria. So about 30% of patients do have a match in their brother or sister. So they're lucky enough to have that. But as far as it's concerned, and same was for Tiana, my brother was not a match and his sister was not a match. So that didn't work out. So what then our hematologists did is that they look for a matched donor, a 10 out of 10, but unrelated. So same story, needing to match. But think about this. I've kind of collated a lock. Imagine you have a lock with 10 different numbers. And for each item, so you got the HLA A, B, C, then the DP, DQ, DR, and you need to match on all of these with someone in the world who has registered on one of the bone marrow donor registries. And it's not easy because actually the probability, for example, that Samantha and I would be a match is 1 in a million, because we need to have that same identical sort of combination to be able to be a match. And it is really tricky. It's really tricky, but 40% of patients that are in a need for bone marrow transplant do find a donor. I had 2 to 3 potential donors, and I didn't realize at the time how lucky I was. And I didn't understand that there was an unequal access. And Tiana had none. And I remember I had been a patient advocate for a year when I met Tiana, and I couldn't quite understand, you know, it seemed to me not so hard because I had 2 to 3. But then I started to dig into the data, and I realized that depending on your ethnic origin, you don't have the same chance. It's not going to be, you don't have the same probability. If you're like me, white Caucasian, the probability of finding a donor on the registry is 79%. But if you're like Tiana, both French citizens, but Tiana was of Malgache origin, his probability was between 29 and 47%. So that at the time was really mind-blowing that we didn't have equal access. So for Tiana, for me, I mean, I was lucky. I had my 10 out of 10 HLA match, but for Tiana, the journey continued. And then, so what hematologists do, then they look for an alternative donor graft. And there are 3 options. So that would be for the remaining 30% of patients. So the first one they go for a mismatched, unrelated donor. So remember, the HLA system, you've got 2 sets of, you know, criteria, well, 2 sets, yeah, 2 sets, so 2 haplos, so 5, 1 and 5, so 10 out of 10 HLA. This is what they're looking, that's what you're looking for. But here, because they can't find a 10 out of 10, they will go for a 9 out of 10, possibly 8 out of 10. So it's historically, the results weren't that good. I mean, you could see on the chart, you see the overall survival, and, you know, for each, as you remove, how would I say, you know, for each mismatch, yeah, that's the term, for each mismatch, there's a 10% decrease in survival. That was the historical data from 2007, but things have improved a lot. So it is a viable option. We can't say it's as good as a 10 out of 10, but this is a viable option still. And you can see that survival rate now oscillates, you know, it's 72, 75% overall survival. The second option are the cord blood units. So this is, you know, obviously, donors would be women giving birth and deciding to give the cord blood, and it would be biobanked. So this is the matching is slightly different. It's not on those, the HLA system is not sort of focused on 10 of those criteria, biological criteria, but they're looking at out of 6. And the matching is not so stringent. It could be 4 out of 6, 5 out of 6. So, and I've already touched on it a bit, but there are advantages and disadvantages to cord blood unit. It is a viable option, don't get me wrong, but because it's come third, it's not as good as a match, a 10 out of 10 HLA. But the advantage is that it's rapidly available. If it's biobank, so these are in a bank waiting for a patient in need for cord blood units. So it's readily available. There's no need to search and harvest the bone marrow in a donor. You know, this is sort of fine that way. The other thing is, as I mentioned, they're not as strict, because for the for the option, you know, the 10 out of 10, this is stricter. You like the combination, you need to match on 10 out of 10 criteria. But for cord blood units, you match on, you know, 6 out of 6, so 5 out of 6, 4 out of 6. So this is kind of easier to find a graft. There is data suggesting there's lower graft versus host disease, and there's lower relapse disease. However, there are disadvantages because the engraftment takes longer. There is also higher transplant-related mortality, increased risk of infections and complications. But it is an option. I mean, if that's the only option, patients should take it. That's the only way out. Then the third option is called the haploidentical donor. So remember, I was talking about how the HLA system is made of 2 sets. You inherit 1 haplo for your mom, 1 from your dad. So if it's a haploidentical donor, what is it then? That means that this is someone in your family, someone related that shares 1 haplo with you. And that expands the probabilities. It's not just siblings. It could be a father and it could be a mother. So on this slide, what you can see is the evolution of the use of grafts for bone marrow transplant. So, and this is French data, but it pretty much mirrors the international situation. So what you can see at the bottom part of the chart, the navy blue color actually corresponds to matched related donors. And you can see that it's been decreasing over time in favor of the haploidentical donors. So that's the lighter blue. So that's sandwiched between the navy blue and the green one. So you see this increase in use of haploidentical donors, so also related donors, but they share one haplo with the patient, while the matched related donor share two haplos. So you see the family, the related donors correspond to those two blue colors. Then you see the green one, the larger bit, is actually are the matched unrelated donors. So anonymous donors on the registry. And these are 10 out of 10 donors, and including also possibly the 9 out of 10 or the 8 out of 10. And then on the top part, you see in a lighter shade of green, these are the cord blood units which were given. And you could see there's been a decrease in use, quite substantial, going from 193 grafts in 2012 done with a cord blood unit to 2021 only 99. So what you can see from this chart is that there has been a decrease in matched related donors, so the 10 out of 10, a decrease in cord blood unit, because haploidentical donors provide new opportunities for grafts. And this is really great because now haploidentical donors represent, 51% of the related donors, which is great. And it's a fantastic opportunity for elderly, because up until recently, a lot of elderly did not have access to bone marrow transplant because, their brother and sister were the same age, not in good form, could not actually donate. But now haploidentical donors who are 70 years old, a lot of AML patients, for example, they can get a donation from their children who are adults. So that's a really great opportunity. So in terms of the hematologist and what happened for Tiana didn't have a mismatch related donor. Sadly, that wasn't an option for him. The haploidentical donor, he had a sister, but she was not a viable sort of option, and I'll explain why. Because it's not just the HLA system, it's really key, it's the point of entry. But what they're looking at also is gender, because it's always better to have a male donor. It gives you better outcomes rather than actually female donors. This is for biological reasons. The age, they will always favor a younger donor. And sometimes they would prefer a mismatch with a young adult, a male, than a full match with a female in her 50s, for example. These are there are different criteria to take into account. The weight, also if the patient has diabetes, if they're smoking or not, if they had prior infectious disease, which would actually make things more complicated, whether they have, autoimmune diseases, lots of different factors on top of the HLA system are taken into account. But that was great that they found actually cord blood unit, but cord blood unit comes with advantages, but also it comes with disadvantages. And unfortunately, Tiana passed away. So this sort of long story to sort of explain the process of, why there are certain options that are being chosen and why it's more challenging for some communities to find a donor. This is really important to understand that as you want to advocate for access to bone marrow transplant. But if you go beyond the existence, so let's say there are people on the registries, so all registries worldwide are connected. They can have access through a common platform. They communicate with each other. So say a patient in the UK does not have a donor in UK registries. The UK registry will connect with all the other registries, and they might find a donor in Germany, for example. But there are situations where you find donors on the registries, and then you identify them, but you need to have what they call a confirmatory typing. So it's promising. The information you have, the hematologists have on the registry shows that they're a potential match, but you need to confirm. And so the donors have to make themselves available. They have to respond. They have to be present. and some actually are just no longer live at a particular address. You could have a match, but they're nowhere to be found. And then you could have a match. They're being called, but they changed their mind, or they realized they didn't understand what it actually meant, or they moved on. Initially, they wanted to give for a child, but they didn't have the collective view of, I would give for someone maybe that I will never meet and I don't know. So you see on this chart, you've got, then, as I mentioned, some people are identified, then they come for confirmatory typing. So 62% white people turn up, but eventually only 51% for confirmatory typing. So checking that the HLA system is actually a good match. But then those that actually do agree and turn up, you have a 10-point decrease. So 51 actually turn up. And you see, according to different communities, you've got different percentages. And this also relates to level of literacy and availability, but also affordability. Not everyone can take time off to give their bone marrow for someone they don't know, and they might not want to do that. So one thing is just to think of initiatives to make sure donors are educated, that they understand that they're engaged in a long-term relationship, because you register today, but you might be called in 4 years, 12 years time, or never. But that there is still this sort of ongoing relationship and knowledge of the potential of saving a life and being able to turn up on the day, the donor is being called. So donor availability, it's one of many factors that impact access to bone marrow transplant. So I've talked at length about donor availability because it is, I'm not saying it's the tip of the iceberg, but it's sort of easy to identify for us patient organizations to sort of engage with health authorities, or in the countries where there is a bone marrow donor registry, but also in countries there is no bone marrow donor registry, but you've got health authorities, you may be able to advocate for the creation of a registry. So this is sort of seems more like quantifiable sort of advocacy sort of action or activities, focusing on finding donors, making sure they're available. But it's one aspect of them, because donor availability is also linked to social factors. As I mentioned, there is, why are there more white Caucasians on the registry? Because this is the reason. There's like overrepresentation of white Caucasian like me on the registry, because there has been wider communication campaigns. Also some social and cultural factors where in some European communities, there's probably less fear of that particular intervention, or more understanding of it. So that definitely has an impact on the recruitment, but also on the availability on the day of being called. So really, have we done everything we could that the donor fully understand the implication of being a potential donor? There's also an economic factor. As I mentioned, not everyone can actually afford to take 1-2 days off, to travel to the harvesting center. So it's not going to be your local hospital, and you need to take some medication, and you might just for the intervention, you'll be out of work, but then you probably will be tired for a few days. Not everyone can afford that. Or feel they can actually do it, especially if they're the main breadwinner and they have nobody else to sort of rely on while they're away. So that's about the donor side, but think also of the patient. Obviously, there's a major barrier to access to bone marrow transplant is the money. In a lot of European countries, bone marrow transplant is covered for by the social security system or the National Health Service, and that's great, but a lot of countries it's just not the case, and it's just it's highly inequitable that way. So there's definitely the notion of differences between countries, and also access to bone marrow transplant in itself. Some patients, even in countries where it is covered for, some patients just feel like they may not be able to go through it financially speaking. They don't want to impose that on their family, because then a carer would have to give up work to be with them, and in some instances patients just feel like they can't impose that on their family. So there's definitely an affordability issue. The poverty problem is very big. It's largely documented in the literature about US patients, because there are more and more, many more literature. There's much more literature in published about US and US situations, but it's documented also in other countries. There is also a system capacity issue, so the structural barriers. So one thing, I'm a member of the World Marrow Donor Association, and I was talking with some people in charge of registries, and I was just saying, there are only 2 registries on the African continent, only 2, one in Nigeria and one in South Africa. That's it. There's no other registries. And I was just wondering, like, what is it we can do as patient organizations to advocate for the creation of bone marrow registries? And they all said, you first have to make sure, there are viable transplant centers. If you don't have a unit that can do bone marrow transplant, there's no use to building a bone marrow registry, because there will be no use for it. And I was arguing against that. I was saying, if you got a bone marrow registry in a particular country, but there's no transplant center, that would still serve patients worldwide. But then the argument is that why would a country actually subsidize for a registry that would not serve their national patients, that would serve international patients? That doesn't make sense. So really, finding ways of how can we support the hematologists to actually acquire the knowledge and have the staff and the capacity to actually, conduct bone marrow transplant. That's just really, really key. And then there's the physician barriers, so the hematologist barriers. Depending on which hematologist you're going to talk to, some will offer bone marrow transplant or not. Same patient, different hematologists, different situations, because hematologists, they have their own bias. They might think, oh, this lady, she's 65 years old. I don't think she will cope with the toxicity. I'm not going to offer that to her. But she may not know that it would be an option for her, because it's a very complex thing. How would you know what the options are offered to you? So there are bias, based on the age, but also the sex. There's, a lot of literature actually that if you're a woman, an oncology patient, you're a woman, you're going to have lesser options, fewer options than men. I don't understand this why, but it's largely documented. And it's the same for bone marrow transplant. So depending on your ethnicity, on your age, on your gender, there will be differences, and then the hematologist will treat you differently. So we really have to sort of make sure medical societies actually train hematologists in expanding their practices, considering different age range, obviously according to guidelines. But hematologists always, like anyone, you do what you're best at, you do what you're good at. You may not want to venture and just use different protocols and different preparatory, different conditioning regimens, because you want to include a new patient population in your practice. So these are like challenges. And then I'm going to talk about some solutions to address some inequalities. So this is not exhaustive for the sake of time, obviously, but there's definitely a place for us patient advocates to take and support registries, also do donor drives, call for bone marrow donor recruitment, and especially to increase the number of registry donors of ethnic minorities, because they have their options are not the same as white Caucasian patients, and that's just unacceptable. So we really have to, as much as possible, try to target the awareness campaigns and the donor drives on those communities that are underserved. Also making sure that donors, and that's regardless of the community they're from, they really understand what they're actually registering for. There are donor drives that actually create a lot of emotions. We had a particular situation in France, which is actually a rare case because we don't actually normally it's not done that way in France, but you have a patient story. So it's a patient story of a little boy in need of a bone marrow transplant. Their parents decided to go on social media, and it created a huge appeal, which was wonderful. But then because some donors didn't quite understand what they're actually registering for, 90,000 people actually wanted to be a donor, but then eventually that was less than half of that, because they actually didn't quite fully understand the implications of it. So really, in the campaign, it's not just trying to create some emotions and just recruiting people, but also making educational and understand that this is really a real commitment. So this is some visuals. You're probably familiar. So Be the Match, it's in the US. This is the organizations that organizes all the awareness campaigns and the bone marrow recruitment campaigns for the national registry program in the US. Then you have also Anthony Nolan, so that's in the UK. That's one of the the organization also that recruits has their own registry. Also have GKMS in the UK, but also in the US, in Germany, and Poland. But they're really trying to focus on, in those countries anyway, in the UK and the US, very much trying to focus on the ethnic minorities. So trying to make this very targeted. And you see on the slide, so there's a link, so from the World Marrow Donor Association, and that will give you access. You can tell, you go there and then you can see which bone marrow registry is the closest to you and which one you can actually promote and advocate for, and that people actually register. So this is also another visual, for community targeted campaigns. That's very much in the US, but that definitely, this is something we would definitely need for in France, because we also have, quite a large, we've got large patient communities. We have patient communities that have fewer options because they're from Africa, from North Africa, and from the African continent, but also from Asia. So the second sort of set of solutions relate really to economic factors. So I know it's kind of big words, and how do we do this? But really, some countries have social security system and public healthcare coverage, but really advocating for the coverage of bone marrow transplant. This is also really key, and also setting up financial assistance program. Quite a few of them are set in the US. But we have situations also in Europe in some patient organizations that actually would just organize some collection, money collection for patient on their journey, so that they can afford not only the treatment, but also just the fact of, you have to start working, obviously. And then you got, also other costs associated with it. Another aspect also around affordability. So I've talked about the patients, but I mentioned it before about the donors. Not some donors would want to donate, but it would be too much of a commitment for them, because they can't stop working for 2-3 days. They can't be away from their family because they can't pay for babysitting fees. They can't. People, they still need to be to look after their children if they have children, for example. So making it, if patient organizations can actually provide that financial support to donors, that's something that would be actually really extremely useful. And then touching on the barriers, so the structural barriers, so the system capacity, we really should, be advocating to the EBMT, so European Blood Marrow Transplant Society, the EHA, but also to ASH, to help increase the system capacity in some countries. So to train hematologists to perform bone marrow transplant, and to keep up with the latest development and the latest practices, so that they're on top of things and they can perform bone marrow transplant accordingly. And also a part of that training, that's the second bullet point in that bucket, is to really improve the graft versus host disease management. Because if you have a 10 out of 10 match, or a 9 out of 10 match, or a haploidentical donor, or cord blood unit, it's not, you GVHD will be different. So the graft versus host disease will be different, and the complications will be different. And I hear so many times hematologists saying, we always find a donor. I'm like, a donor, yes, but we want the best donors. We'd like ideally to have a 10 out of 10 match. But if we don't, then we need to improve ways in managing graft versus host disease, in managing the complications, because a person that receives cord blood unit versus one that's 10 out of 10 matched donor, they should have the same chance of getting through this and living a normal life with reasonably good quality of life. So just improving that, and also teaching on hematologists how to better manage graft versus host disease. And I'm going to conclude on a slide. So from the meeting from the World Marrow Donor Association this year that took place in October, and there are two nuggets really that I collected from that meeting. First one was the notion of super donors, which sounds really exciting, but it is. So super donors made from cord blood units. So we've got cord blood banks that have been, how would I say, their use has been decreasing, but we still have all these units. And now the World Marrow Donor Association is actually working on using those to create sort of what they call pluripotent donors. So donor that would be universal, that could be used just at will. And it seems like science fiction, but I was really exciting and really promising. Doesn't mean we would not need bone marrow donor registries, but it would be something, an additional option. And another aspect which I felt was really also exciting is the donor readiness score, because they mention on it multiple times that you find a donor on the registry, the donor looks promising, and then, but you've got, for example, multiple matches, depending on the ethnic community. So, but say white Caucasian, have 3-4 different options. Which one are you going to call first? Which one is the most likely to actually turn up? Because sometimes you choose one, but they don't turn up on the day. It does happen. A donor say, yes, I'm coming, and they're not coming on the day. And this is a death sentence for the patient. So they need to sort of make sure they have developed an algorithm to determine which of the donors we should go select, call, ask for the confirmatory typing, trust them that they will turn up on the day. And they've developed this, and I think it's just really, really thrilling. And that's it for me, and thank you very much. And I'm available for questions and discussions. Also, I'm really looking forward to hearing your own experience with your own bone marrow donor recruitment campaigns and challenges.
The chat. However, since we have a relatively small audience, maybe if someone wants to speak up, we can reactivate the microphone. So just raise your hand or let us know. Okay, Bahija. So just give me 1 second. Okay, so Bahija, I think you can unmute yourself. Thanks. Hi, Bahija.
Hello, bonsoir. Hello, everyone. Hello, Samantha. Hi, I'm Pierre. Thank you very much for your presentation. It was very interesting. I want to add something about culture and bone marrow transplant, like blood donation. People, especially in our region, for example, in Africa and Middle East, they are afraid, they are scared about donation. And we should maybe raise awareness about this, because people need to know that they will save lives if they don't donate, blood or bone marrow. And also some some issue in you already mentioned in health insurance. We have a lot of problem of this in our region, but culture and mentality still the first one. Thank you very much.
Mm. Yeah, no, that's what I was relating to, social factors, and I completely agree with you. This is something that's been reported multiple times. It's the people being afraid of needles, being afraid of feeling pain, being afraid, also sometimes being afraid of being a guinea pigs as well. So there's just things that are not, it's no laughing matter. People are generally scared or afraid. So just I have to find ways to reassure potential donors, the general public, that donations are safe. I mean, they're extremely safe in the sense there's so many exclusion criteria. When I was looking, when I was told that I needed a bone marrow transplant, I shared information with friends, encouraging them to actually donate. And a friend of mine told me, I can't be a donor because I'm allergic to peanuts. I was just saying, are you joking? And I was like, no, I'm allergic to peanuts. And, they just want to make sure that it's not going to be a problem for the patient, but also for me, if I'm allergic to this, it could be a problem in the intervention as well. So this is just more like an anecdote, but there are lots of different reasons why they would not accept a donor. So they're really trying to protect donors very much. They make sure that they are protected.
I think it's also related to some personal history. For example, when someone adopt, for example, a child, and later they discover, for example, they had this secret, and they keep this secret to only the family. Sometimes they are because I faced this problem in Casablanca once. I remember very well, maybe 10 years ago, and the lady was afraid that the child will discover that he is adopted. And then when you are doing, for example, Ashela, I don't know in English how we say the Ashela.
Yeah, HLA,
yeah.
yes.
Yeah, and they are afraid to discover, all the reality about adoption. I think it's cultural, and it's also something because you will search in the history of the family, and sometimes when you are hiding something, you are afraid to discover something about this history.
I agree, and actually spoken to hematologists that actually say that sometimes you find out that the father in the family is not the father. So the father,
Exactly.
It's just from two different. You've got the patient has two siblings. One sibling has the same father, the other one doesn't. But no, they don't know. The father doesn't know. Only the mom knows, but she won't tell. But when I asked them, what do you do? They would say nothing. We don't comment on it. That's it. We just say they're not a match. They don't have access to the information. But to your point, some patient, a mother, for example, in this situation, would just may create some. I'm not saying barriers, but it could be very problematic, for the family dynamic, and so that I hear you there. There are different issues. And apparently it happens quite a lot, so that they mention it. I was really surprised.
So, can.
Yes, hello. Can you
Hi,
hear
Stephanie?
me?
Yes.
Great. Thank you very much for this presentation. It was really very interesting. Thanks a lot and very clear. The only thing I don't know well bone marrow transport, but I feel like people are maybe afraid to have a bone marrow transport because they don't know what that means really for them. And I was wondering whether it would be interesting when we do a campaign awareness to give maybe, I don't know, statistical or I don't know what else, information on how many people have suffered from pain, how many people have stayed a long time at hospital, I don't know. But, you know, in order to give information to the donor about what that means for him. Maybe it would be great to include that in the campaign awareness in order to really to inform people really on what that means for them.
No, I agree. And there, it's sort of a double-edged sword because, you know, if you tell people it's not that painful, then they think of pain. You know, it's a challenge.
Yeah.
But at the same time, it still is a question. So the French donor registry has for a long while focused a lot on pain, you know, just saying, you know, it's not that painful and trying to explain. And it has had some, I would say, modest success. And the registries that recruit the most focus on the patient stories and focus on the opportunity to save a life, which is a higher drive. But that doesn't mean this. I think as the major drive, I think this is more like, you know, as you decide and you're motivated, people should be informed on the potential, you know, of pain and what actually that would mean. I understand, but it's challenging on that particular front. Something I actually had not included it because I could have gone wild on the number of slides, but you know, the bone marrow donation, people don't understand that it's actually not in the spine. People, especially in French and Spanish and Portuguese, it's just, there's a confusion in that particular sense. Moelle épinière, you know, and moelle osseuse. But in 80% of the time, they collect the bone marrow, the stem cells, through the blood. So it's like a platelets donation. So I'm not saying it's fun, but you're not going to be, you don't have any anesthesia and you don't have a needle in the bone in the sacrum. But in 20% of the time, they ask the donor if that can actually go through anesthesia and do it. But I think there is information, but I don't know, in terms of like doing a donor campaign, focusing on the pain, I think it might scare actually people away.
Yeah.
I think it should be a second step.
Yeah, I understand. Okay.
Because it's like, you know, don't think of the pink elephant and you're straight away you think of a pink elephant, right? So it's this sort of dynamic.
Yeah.
But it is a barrier. And actually another fun fact, but 65% of registered donors are female. 35% are male. I mean, and there is this notion, and it's not me being sort of critical and, you know, being nasty or anything. It's not that. It's just mentioned by registries. They just say, because they, you know, they do like, I'd say, studies. I mean, the sort of research, you know, it's not market research, but, you know, they try to understand, they do panels, and men are more afraid of medical interventions than women, and in the same way that male don't always just book their own doctor's appointment when they have one, is because it's their sister, their wife, or their mother. You know, this notion of there are gender issues on the behind donation, and that's a problem because the best results come from grafts from male.
All right, thank you.
Yeah,
I think there's something also maybe, and you mentioned that in your slides, but because I'm on the registry since 20 plus years something, but I changed country. Then when I came in Switzerland, I reopened like a dossier to make sure I was still on the list. And then I changed the city from where I live, and it's not the same canton. So there's two different entities. And I've realized like very recently that my dossier never followed me. So I think there's also like lost potential donors just because of administrative issues.
Yes.
And to be honest, when I moved, I didn't think at all that I should as well inform the centers that I was moving and that my address was not the same address and that my phone number has changed and da 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 da. So I'm just thinking maybe there's also something kind of proactive message as well to donors to say, just make sure you are still on the registry, just make sure if you are moving that you're thinking about calling again, on maybe all these things, because it is something very stupid, but it can, you know, I've lost about 10 years because my dossier was somewhere, sitting on a shelf somewhere, and I just didn't think that I had to do something, which is very frustrating as a donor as well. Plus it, I think it doesn't give a right message also to the thing, because you are motivated and you want to be a donor, but you are not.
But you forget, and that's one thing. And there have been, I can't recall exactly which country, but there some patient organizations that actually managed to get some sort of partnership with the national, like, post office services. You know, when you move, you always ask for your mail to be forwarded, but then they managed to get some sort of thing that in the form they said, well, are you a blood donor, a bone marrow donor? Have you thought of changing, you know, your address? Just to add that in, so trying to get a partnership with the National Post Office, so that, because people, you know, you check, and you think, oh yeah, actually I'm a, you know, bone marrow donor, I should do that. Otherwise you forget about it, you move on.
Okay. Yeah, exactly.
Yeah. I see Bahija maybe has a new hand. I'm not sure.
Yes, please. I want to add something about media awareness. We would never seen any, for example, any show or any anything in the media, in TV, particularly about donation, even blood donation, or some, for example, speaking or telling some stories about donation and how to save people's lives. I think because we have, in other side, when it comes to blood, we are afraid because there are many stories of contamination. For example, with dentists, with you know, when you donate, for example, blood, we have some story about contamination of your blood because you have AIDS, you have many things. But other way, we don't have any awareness, any media awareness to for example, to raise you know, issue, and how to give guarantee to people, to motivate them and to show them the reality about donation, how the process is, to encourage them to make donation and to participate in this life saving.
But in your country, so Bahija, it's the bone marrow transplant, it's between brother and sisters only, right? It's because there's no registry. So that would be brothers and sisters, either 10 out of 10 or haplo donors. So that would be the case.
I'm talking about donation in general. International also donation, or donation bank, or donors bank. We should motivate people to donate, because it's something I never seen any for example media awareness or show about this. Never. In Morocco or outside, I didn't see anything like this, for example, to talk about some stories, show people how the process is made to ensure you know, the quality of donation, something like this. But other way, we have all this bad stories about contamination blood, in donation blood, or dentist or something like this, and then people are afraid about this. Even well educated, they will not donate their bone marrow or blood in general.
Yeah. So if there's like already that big sort of hurdle for blood donation, bone marrow, it's even another step, you know, because it's just even more demanding. And often bone marrow donors are blood donors. A lot of blood donors register more easily for as bone marrow donors?
They are afraid about contamination. It is because no guarantee if it's good or not.
And have you had the chance to mention to the Ministry of Health in Morocco, like about, you know, blood donation, for example, to start with? Like, why don't they do campaigns? Have you?
They did blood donation, but it's not enough. Only, for example, usually once a year, you know, when we have some, you know, some occasion. It's not always and permanent, for example.
Yeah, no, I understand. It's a challenge.
I mean, I'm living in Switzerland and I basically have to travel almost 40 minutes to actually be able to give my blood. And then when I'm going there, I have to sometimes queue for like 1 or 2 hours before I can actually give my blood. So it takes like a full process as well. And it's so I can also understand that people are not, I mean, no, I don't understand, in fact, but I can be a bit less blunt to say, yeah, I can understand why people don't take 3 hours of their time and go and give their blood, and then it's their own cost as well, because you have to take the car or the public transportation and da 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 da. So it's not very encouraging as well.
And for donors, for bone marrow donors, they will arrange. So the registry, the you know, the healthcare system where the patient lives, you know, and the healthcare system that covers, you know, the bone marrow donor, the bone marrow transplant, they will pay for the travel. They will pay the donor, you know, if they need to travel. That, you know, when I say the travel, I'm not saying that an American donor would fly to France. It's not that, but an American donor, let's say, in a particular state that would actually need to, you know, the collection, the harvesting of the stem cells cannot take place in any place. It has to be in a very specific center. So they would have to travel this particular center, take the time. As I said, you know, you take medication, the donor has to take growth factors. So they just need to make sure that their bone marrow is going to produce more stem cells than normal, so that they can be, you know, they can be, some of those stem cells can be collected, and then they can get on with their lives, and there's no impact for them. But all that time and the effort, yeah, not everyone is willing to do it. And sometimes there's a will, but sometimes there are some economic factors. Some people just realize they can't do it. It's just too much. You know, they need to take time off, and then someone needs to look after the kids. Or, you know, they can't afford sometimes, you know, some people can't afford, like, you know, the cost of transport. If it's not covered, it should be covered. But you know, not everything is always very clear. Or sometimes people think their costs may not be covered. They anticipate, they don't actually know, and they decide against it without having the full information. That's also a problem. So it's about educating the donors of the commitment, potential donors, educating them about how safe the process is, as Bahija said, you know, and that, you know, they should not to worry for. Also, you know, communicating once they are motivated, just to reassure them on pain, as Stephanie mentioned. I think it's really important, but probably not as the first message, but definitely as a second, third message, that, you know, reassuring them on how the process is, that certainly helps. And there's a lot of information on the World Marrow Donor Association website as well. All the information is sort of concentrated there.
Okay, so I think we are coming at the end of the hour. As usual, so I'm going to post the presentation from Anne-Pierre and also the recording on the website. So if you want to share it further or rewatch it, then you have this opportunity. And with that, so thanks Anne-Pierre for this very nice talk. It's nice to have you with us today. And so wishing you all a very good afternoon, morning for some of you, and looking forward to see you again soon.
Thank you everyone.
Thank you.
Thank you very much. Have a good day.
Thank you, Samantha. Thank
Have
you,
a nice
everyone.
day. De rien.
Bye
Bonne
bye.
journée.
Merci, au revoir.
Au revoir.
Ouh.